The big picture in the end of the day that I'm aiming for is this thesis. Since the development of medical holism, medicine has been philosophically confused about dualism, and this has led to harm in clinical practice. When we correct the confusion, we find that naturalistic dualism is the simplest and safest way to make sense of medicine's position on the mind. Okay, this is a very, very quick and far too general history of the series of events that occurred before we got to medical holism. So very, very roughly and broadly speaking, medicine is traditionally working with a model that's focused on the body and its diseases in a mechanical sort of way. In the 1970s, the medical professions and the public recognized a quality of care crisis with that model. And that led to humanism as a kind of an ethical resolution that would improve the biomedical model in an ethical way. But it also led to holism as a conceptual resolution that would change medicine from a more fundamental philosophical level. The primary speaker for holism in the 1970s was George Engel. He was a psychiatrist. That's George Engel there. And what he proposed is that you need a conceptual foundation in order to make sense of the ethical ideas that humanism is proposing for medicine. So Engel says appeals to humanism are ephemeral and insubstantial when not based on rational principles. So holism is not saying we can fix the biomedical model by adding ethics. He's saying we fix the biomedical model by changing the conceptual foundation, and then that will explain why we need ethics. Second, holism challenges the conceptual foundation for medical science. So Engel says, I contend that all medicine is in crisis, and further that medicine's crisis derives from adherence to a model of disease no longer adequate for scientific tasks and social responsibilities of medicine or psychiatry. So the goal there is really to change the way that we understand medical science, and particularly the way that we understand disease. Specifically, holism wants to broaden our concept of medical science to include experience. So we're now faced with the challenge of broadening to broaden the approach to disease without sacrificing the enormous advantages of the biomedical approach. 25 years after Engel wrote, his successors at the University of Rochester did a 25-year retrospective, and they framed it this way. Engel didn't deny that the mainstream of biomedical research had fostered important advances, but he criticized the excessively narrow focus for leading clinicians to ignore the possibility that the subjective experience of the patient is amenable to scientific study. So holism comes out in this broad picture to be a way of understanding the patient's experience as an essential contributor to diagnosis and health outcomes and humane care. Sorry, my slides are not advancing. Okay. Finally, holism provides an alternative to the biomedical model, a specific alternative, the biopsychosocial model, where clinicians attend simultaneously to the biological and psychological and social dimensions of illness. So it's not just an exclusive focus on the biological. I raise this because I think most people do equate holism with the biopsychosocial model, but I raise it just to say that I will not talk about the biopsychosocial model again. My sense is that there are other ways of cashing out the conceptual changes that Engel proposed. There are problems with the BPSM that are not problems with holism generally. So while the language of holism is very often the language of the BPSM, this is really, the specifics of this model are not going to be of concern to me in this talk. So it is very hard to overstate the enormity of the influence that holism has had on medicine. So here's how Seppian in 1997, rejection of biopsychosocial medicine is tantamount to a betrayal of one's profession. Then more recently, there's Rees in in 2014, the biopsychosocial model is the official philosophy of the American Psychiatric Association and the DSM-5. Then, according to the WHO, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So the ideas of holism, I mean, there has been a great deal of discussion about whether the BPSM has been successful, what its goals are, whether it's confused, what we need to do instead. But there is no question that that holism has had a profound influence on medicine's understanding of its own goals. So that leads us to this fundamental question. If we do understand holism as the antidote to the biomedical model, what exactly is the malady that it cures? The nice and clean version that we normally hear of that is this quote from Engel. The biomedical model embraces reductionism, the philosophic view that complex phenomena are ultimately derived from a single primary principle. That all sounds very reasonable, philosophically speaking. Unfortunately, sorry, I'm having a real problem with my slides. Here we go. Unfortunately, the actual quote from Engel with all of these little dots that I have in there, if we fill in those little dots, this is what Engel actually said. The biomedical model embraces both reductionism, the philosophic view that complex phenomena are ultimately derived from a single primary principle, and mind-body dualism, the doctrine that separates the mental from the somatic. So this is very puzzling. How can the biomedical model be understood to embrace both reductionism and mind-body dualism? So there are ways in philosophy of mind in the last 30 years to make sense of that, of course, but it seems clear that Engel was not working with a very sophisticated philosophical picture, very hard to see what it is he's getting at here. Unfortunately, it's not just one time that he says that. Every time he characterizes the biomedical model, he characterizes it in this extremely confusing way. The biomedical model can make provision neither for the person as a whole, nor for data of a psychological or social nature. For the reductionism and mind-body dualism upon which the model is predicated requires that these must first be reduced to physical-chemical terms before they can have meaning. So this is extremely confusing. First, that it's based on both reductionism and mind-body dualism, but also the idea that dualism would lead you to reduce data of a psychological nature to physical chemical terms. So I think most people read this material and think, well, medicine is confused about mind and body. What's the problem there? We can kind of adjust and get the general idea. Unfortunately, the confusions built into Engel's writing were common among all the people writing about holism at that time. And these confusions have proliferated and deepened over the last 40 years in a way that's led to very serious problems in medical writing about mind and body. So what I'm going to do now is present some of just a selection of common quotes from medical writing about mind and body that will be deeply puzzling for philosophers. I raise these not to say, look at this is terribly confused, but to say, wow, this looks terribly confused. Then I'm going to go back in a couple of minutes and explain that it's not actually confused. It's just that they're using the basic terms in a very different way from the way that philosophers use them. So, okay, here's Sullivan in 1986. The Cartesian division of the person into mind and body is basic to the reductionist approach of medicine and therefore the source of its tendency to ignore the human dimensions of health. Here is Paley in 2000. To reject dualism on the face of it is to leave open the possibility that the mind can have a more significant role in illness and in healthcare than medicine has traditionally envisaged. So to reject dualism is to become open to the mind. And here is Gendel in 2016, dualism discounts the significance of mental states in the maintenance of health. So here is the problem that I'm going to try to address in the next two sections. If we accept that holism is right about the importance of bringing the mind into the exam room, and I should say that's not an issue I'm going to debate. I'm going to assume that we all accept that holism was on the right track with that change, and then ask where we end up. So to the extent that holism is right about the medical importance of both mind and body, it seems straightforwardly threatening for the profession to embrace an incoherent position on dualism. So here is the question that we need to try and answer. What are the WHO and the American Psychiatric Association and the everyday practice of medicine actually doing when they set out to do away with the reductionism and mind-body dualism inherent in the biomedical model? Okay, there is a simple answer and a hard answer to that question. The simple one is just a matter of terminology. The first difference between medical writing about mind and body and philosophical writing is that in medical writing, there is a misunderstanding about reductionism. So writing about holism recognizes Descartes as a methodological reductionist about the way that we should approach medicine. But then in medical writing, there's no distinction between methodological and ontological reduction. Really, the question of ontological reduction is not on the radar. That's something I'll discuss in detail. So as a result, Descartes is described as a reductionist simpliciter. So people just sort of slide into saying that Descartes is a reductionist about the mind. So it's certainly clear that Descartes recommended a reductionist approach to method in medicine. The human body may be considered as a machine so built and composed of bones, nerves, veins, bloods, and skin that even if there were no mind in it, it would not cease to move as it does at present when it is not moved under the direction of the will. At the same time, of course, Descartes was very firmly opposed to ontological reductionism. That's going to be obvious to philosophers. I knew from this that I was a substance, the whole essence or nature of which was to think, and which in order to exist had no need of any place and does not depend on anything material. So for medicine, if you're not going to distinguish methodological from ontological reduction, you're going to come away saying that Descartes was a reductionist. And of course, that's going to be an extremely confusing thing to say in the company of philosophers. Second, I think that medicine misdefines dualism. So as with reductionism, medical writing about dualism actually ignores the ontological debate. So it doesn't actually take a position on the question of whether minds or mental properties exist. Instead, dualism is defined in epistemic terms as the separation of mind and body in our thinking or our words or our medical methods. So this is a complicated business. Dualism certainly is about separation of mind and body in a sense. Here's Cassel, a colleague of Engels, roughly speaking, giving the narrative that's certainly common and accurate. Cartesian dualism made it possible for science to escape the control of the church by assigning the non-corporeal spiritual realm to the church and leaving the physical world as the domain of science. There is nothing about that that's inaccurate. It's certainly true that Cartesian dualism separates mind and body. The thing is that that is not all that Cartesian dualism does. Dualism is primarily an answer to an ontological question. How many kinds of substances or properties exist? That is the question that dualism primarily answers. So if we look at where these two misunderstandings leave us, we can make sense of those very confusing statements. If we define reductionism as a methodological idea, and we define dualism as an epistemic idea, then reductionism and dualism will actually be compatible. In fact, if reductionism is a mechanical approach to the body and its diseases, and dualism is separated, in fact, if reductionism is a mechanical approach to the body and its diseases, and dualism is the separation of mind and body in our thinking, then dualism will actually be necessary for reductionism. So I think this is the picture that people are working with when they write about mind and body in medicine. So we can go back to this very confusing quote from Sullivan: "The Cartesian division of the person into mind and body is basic to the reductionist approach in medicine and the source of its tendency to ignore the human dimensions of health and disease." What he's actually saying there, when we understand the way that medicine uses terms, is that Descartes' separation of mind and body is necessary if you're going to adopt a medical method that focuses on the body and its diseases without concern for the human dimension. So that's a perfectly sensible thing to say. It's an insightful thing to say. It's just said in language that's very different from the way that philosophers use the terms. So when I sorted this out, I thought, oh, hooray, I have figured out how medical terminology about mind and body and philosophical terminology about mind and body work. And now medicine and philosophy can talk and everything's going to be fine. Unfortunately, that is not the case. Fixing holism's terminology does not make holism philosophically coherent. Because at the root of holism's picture of mind and body, those confusions seep in and divide the way that we understand medicine's goals. The heart of the problem is this. If you define dualism as separation of mind and body, and then you affirm dualism, no problem, because every case of dualism will separate mind and body. But if you define dualism as separation of mind and body, and then you reject dualism, then you have some issues, because you're not actually rejecting dualism on an ontological level when you do that. You can, as someone working in medicine, you can reject the separation of mind and body as a dualist by saying, okay, there are minds and there are bodies, or there are mental properties and physical properties, but when we do medicine, we should seek to unite them in an integrated way. At the same time, you can reject separation of mind and body as a reductionist. So you can say, okay, it seems that there are minds or mental properties, but really there aren't. It's all physical. And so it's a mistake to separate mind and body, because in reality, everything is actually physical. The trouble is that the equivocation of terms in holism is so pervasive that holism actually sets out to accomplish both of these goals without recognizing that there are two goals, without recognizing that they are contradictory goals. This is the heart of the problem. So a great many people who write about medical holism assume right off the bat, without debating, that medical holism is a non-reductive approach. Your goal with holism is to reject reductionism. So here's Zucker in the 1980s saying, holism is a strategy that stresses dualist interactionist theory of mind and body. Then you get Markham saying that the biomedical model is mechanistic monism, and that the remedy for that is holism/dualism. Then in 2015, you get a more specific account from Woods. Holism requires that the medical gaze toward the person is not one of eliminative reductionism. So this all looks very natural and reasonable to philosophers as a way to cash out the change from the biomedical model to the holist perspective. Unfortunately, the equivocation of terms has made it so that there is a very powerful strand of holism in medicine that understands the goal to be rejecting dualism, not rejecting reductionism, but accepting reductionism and rejecting dualism, not actual dualism, not an ontological position, but dualism as the separation of mind and body. This kind of approach is most common, at least foundationally, in psychiatry. So there are a couple of studies that set out to show that unfortunately, psychiatrists continue to separate mind and brain, and that this is a big problem. So in 2006, there's Maresco and Kurmaya with this paper called The Persistence of Mind-Brain Dualism in Psychiatric Reasoning about Clinical Scenarios. Mind can be reduced to purely material and deterministic neurological mechanisms, despite attempts in psychiatry. Based on a biopsychosocial model, social scientists have observed that psychiatrists continue to operate according to a mind-brain dichotomy. And on this strand of holism, it just goes without saying that if you see any separation between mind and body at all, that is dualism, and that is the thing that we are trying to eradicate. In the second study in 2009, Dualism Persists in the Science of Mind, the survey revealed a predominance of dualistic attitudes, emphasizing the separateness of mind and brain. That's dualism, separateness of mind and brain. In clinical practice, the adoption of the biopsychosocial approach provides an antidote to separation of the care of diseases of the mind from those of the body. So this is where we end up with at the end of section 2. It's not possible for holism to offer a remedy for dualistic reductionism, as Engels suggested. So what are holists actually aiming to do? As a result of terminological confusion about reductionism and dualism, understanding of holism's goals is conceptually divided. Some see its chief goal as the rejection of reductionism, while others see its chief goal as the rejection of dualism as separation. What's really important here, I think, is that, this would all be perfectly fine if people were debating these two ways of understanding medical holism and what we're aiming for when we reject the biomedical model. Unfortunately, there is no awareness that these two strands of holism exist. And so there is no debate between them. What has ended up happening after 30 years of effort in this direction is that if you ask people working in these areas what they're doing with mind and body, they'll give you a picture that somehow attempts to combine these two goals in a way that's just not coherent. So, okay. I'm going to shift gears here a bit to try and clarify how the conceptual incoherence that we end up with, given the terminological confusions in the foundations of medicine, I'm going to try and clarify how that incoherence actually plays out to be a problem at the level of clinical practice. So here are the two strands, the two options that we have for understanding what we're trying to do in medicine once we embrace holism. On the non-reductive holism side, the point of holism is to reject reductionism. So we're going to bring mind into the exam room. Both views are going to bring the mind into the exam room. But with non-reductive holism, we're going to bring the mind into exam room as mind. We are never going to equate facts about experience with facts about the body, because if we do that, then we're back at the biomedical model. And so we will bring the mind into the exam room, but we will continually draw a clear line between the mind and the body so that we never lapse into the reductive picture of the BMM. If we embrace reductive holism, on the other hand, our goal, our primary goal, is to reject dualism as the separation of mind and body. So we're going to bring the mind into the exam room, but we're going to bring it into the exam room as body. So the goal here is to always understand facts about experience to be facts about the body, because we're assuming a reductionist foundation. And so in the end of the day, as a matter of practice, our primary goal is to eliminate the mind-brain dichotomy. So that is the primary difference. Non-reductive holism maintains a clear line between mind and body, though both of them are going to be present. Reductive holism, the goal is to get rid of that line and make sure that nothing in practice ever draws a line between them. I think that it's clear before we step into a scenario where we're looking at how these things play out in practice, just on a purely conceptual level, there's nothing about non-reductive holism that is intrinsically problematic. There's nothing about non-reductive holism that's internally inconsistent or in any way obviously troubling, philosophically speaking. But with reductive holism, we have some really serious problems. First, combining reductionism and holism is just, even inside of medicine, outside of medicine, in any context, holism is going to unite a lot of different things that seem disparate into one unified picture. Whereas reductionism is going to tell us, well, it looks like you have a lot of different things, but in reality, you don't. So combining reductionism and holism seems confusing right off the start. But more deeply, it seems very puzzling to understand how we can possibly combine reductionism with holism in a coherent way. If we're going to equate all the facts about experience with facts about the body, if we're going to set out to eliminate the mind-brain dichotomy and understand all experiences as bodily things, then it seems we're back to the biomedical model. So reductive holism involves a kind of conceptual backbend that before we look at anything in practice just seems too big of a stretch to be tenable. So you might think, if you're a philosopher who just doesn't work in medicine, particularly in these areas, you might think, well, okay, that's going to be a weird view. Not many people are going to adopt that view. But in reality, reductive holism has had a profound influence on everyday medical practice. The transition from armchair philosophy to clinical care is through, for reductive holism, is through the vagueness thesis, the idea that the boundaries between medical and mental health conditions must be intrinsically vague. So the goal, again, of reductive holism is to get rid of the mind-brain dichotomy. And this naturally leads to the idea that the boundaries between medical and psychiatric conditions must be vague. So here in the Foundations of Psychiatry, we see that idea spelled out as basic to what we understand psychiatry to be doing. So in the introduction to DSM-4, the term mental disorder is unfortunately implies that there's a distinction between mental disorders and physical disorders. That's an anachronism. We no longer think that there is such a distinction. The term persists in the title of DSM-4, Diagnostic and Statistic Manual of Mental Disorders, only because we haven't found a better word. Then in research for the preparation for DSM-5, we get this: mental implies a Cartesian view of the mind-body problem. The term psychiatric disorder might be preferable because it emphasizes that these conditions are not purely mental, and that the line between psychiatric disorder and other medical disorders is not a sharp one. So we can see very clearly that in these foundational writing for psychiatry, we're assuming the vagueness thesis, that boundaries between medical and mental health conditions are intrinsically vague. And that idea really has to have its roots in reductive holism rather than non-reductive holism, which is going to be very firm about drawing a clear line there. If we want to track the vagueness thesis and reductive holism as they play out in medical practice, the place to do that is with the patient group that's gathered around the mind-body diagnostic line. And in medicine, that would be the group of patients with medically unexplained symptoms, or MUS. MUS are just the I don't know symptoms. They are the symptoms that remain undiagnosed after the patient seeks medical care, the clinician sets out to make a diagnosis, and then no diagnosis is discerned. Because MUS are really just the I don't know category, they can be caused by unrecognized disease, they can be caused by benign bodily issues that are not really diseases that are just going to pass, or they can be psychosomatic. Psychosomatic is, broadly speaking, defined this way. Psychosomatic is just mind, body. Psychosomatic symptoms are not attributable to verifiable, conventionally defined diseases because they are caused by psychological conflict that is transformed or transduced into bodily distress. I think most people are inclined to think that not getting a diagnosis is unusual in medicine. But in everyday outpatient care, that is just not accurate. MUS have, the term MUS has a whole lot of different definitions, and depending on your definition, you will come up with a different prevalence. In a paper I wrote in American Journal of Bioethics, I walked through all of those definitions and the prevalence that we get for each of them, and end up concluding that MUS are roughly as common as diagnosed symptoms in outpatient settings. So for every patient who gets a diagnosis, you have a patient who falls into this I don't know category. So this is not an everyday, this is not a now and then kind of thing. This is kind of the bread and butter of everyday outpatient care. For the last 30 years, directives for managing unexplained symptoms in medical education and textbooks and practice guidelines have been based on research not from medicine, but on research from psychosomatic medicine, which is a subdiscipline of psychiatry. Psychosomatic medicine is, of course, the area of mind-body overlap in psychiatry. So, of course, psychosomatic medicine is defined by the vagueness thesis. Here's Schwab in 1985. With the established principles of psychosomatic medicine, there is a lessening of the tendency to view the patient dichotomously as being organic or functional. The specialist instead conceptualizes the patient as a total biological unit. So the idea there is that psychosomatic medicine is saying, do not try to decide whether the explanation for these symptoms is in the body or in the mind. Instead, just see it as a mind-body overlap kind of thing. Creed says, in the end of the day, psychosomatic medicine is defined by the necessity of not trying to force these disorders into either a mental or a physical classification. So again, you get a patient who ends up in a situation where the explanation could be mind, could be body. And what psychosomatic medicine is going to suggest is once you're in that situation, stop asking questions, because it's not in patient's best interest to draw a line there at the mind-body diagnostic line. So because psychosomatic medicine has actually been directing this area of medical practice for 30 years, the term MUS is actually now understood as a diagnosis. So it's really not a category of I don't know. It is just defined as a diagnostic label, and it is in the International Classification of Diseases for Primary Care. It's a diagnosis that is actually classified in psychiatry and always understood to be ideally managed in psychiatry, even though patients are generally reluctant to seek psychiatric care. Of course, the trouble with seeking deliberate diagnostic vagueness anywhere, but particularly at the mind-body diagnostic line, is that error is going to be possible at that line. If you define every patient as having a mind-body overlap disorder, you're going to think that there's no way you can make a mistake at that line. So disease-specific organizations and patient organizations have been very concerned to clarify a problem with error in this area. 51% of autoimmune disease patients report that they've been denied medical care on the basis of mistaken psychosomatic diagnosis. And studies suggest that that diagnostic delay for rare disease patients is tied to mistaken psychosomatic diagnosis. So for rare disease patients, diagnostic delay is anywhere from 4 to 7 years. So that's a really big problem for rare disease patients. The thing is that rare diseases are not rare when taken collectively. Every rare disease is rare in itself, but together there are so many patients with rare diseases that there are roughly as many in number as there are patients with diabetes. 1 in 10 Americans has a rare disease. So if we take conservative estimates of prevalence for these two categories, and we assume that only half of rare disease patients struggle with this problem, we end up with the conclusion that there are 12 million Americans who have suffered from diagnostic error at the mind-body line. The thing is that there is no research in psychosomatic medicine or in medicine to try to pin down the nature of this error or to resolve it. So this problem comes to a head with the enormous challenge of long COVID. The CDC reports that 35% of those with confirmed COVID infection continue to be ill at 2 to 3 weeks at the point where active infection is no longer detectable. And very surprisingly, that 1 in 5 previously healthy young adults continue to have symptoms at that point. So Greenhalgh and colleagues published the first kind of guide for managing long COVID in primary care just in September. And they distinguished 3 kinds of COVID patients: those with threatening ongoing challenges like clotting disorders, those with rehabilitative challenges related to ICU care. And of course, those 2 groups are going to be patients who are normally older, patients who had initial health conditions that made them particularly susceptible, patients who had more serious initial infection. But then there is this 3rd group of patients who are younger and who had a milder initial disease, but who go on to have nonspecific symptoms that persist for weeks or months after active infection: fatigue, exertion intolerance, trouble breathing, brain fog. When I say long COVID from this point, it is this very confusing group of patients, the largest group of patients with long COVID, that I'm going to try to understand. Greenhalgh and colleagues go through some calculations. I'm going to go through this quickly, where roughly speaking, if we base all of this on conservative estimates, we end up with a rough guess that there are 60,000 people in the UK with post-acute COVID-19. If we apply those same very conservative methods for calculation, it turns out that there will be, by the same standards, 1.4 million people in the US with long COVID. And as of this week's rates, that figure rises at a rate of 10,000 new long COVID patients a day. So of course, many of these will recover quickly, but according to the best evidence that we currently have, roughly half of these patients are patients who have long COVID for many months or who have not recovered yet. So long COVID is a mind-body problem. We don't have an explanation of the path that leads from active infection to long COVID. So the default option, if we do nothing else, is to construe it as unexplained symptoms. So as a mind-body overlap disorder best addressed by psychiatry. At the same time, we do have research suggesting that mild infection with COVID-19 does result in immunological damage and neurological damage and cardiac damage. And at the same time, the patients are extraordinarily active and organized in the effort to drive biomedical research and practice recommendations that will lead to recovery. And the most active group among these patients is the group of long COVID patients who are doctors. Non-reductive and reductive holism explain the division in approaches to long COVID, but it's important to recognize that both of these approaches will invite psychological explanations for the symptoms of long COVID. There are a lot of different ways to cash out the way that psychological distress can lead to an experience of illness. Non-reductive and reductive holism both are concerned with and open to all of these explanations. The difference between the two approaches is that non-reductive holism will recognize all of these possibilities while it still remains committed to the possibility that long COVID is a chronic disease caused by COVID-19 infection. So here's what non-reductive holism looks like with long COVID. This is Avindra Nath. He's a researcher at the NIH who was working on chronic post-viral disease even before long COVID. He writes in Neurology, I think just last week, we need to conduct research to determine the biological basis of long COVID. But as we put these efforts into place, it's equally important to remember that we should study not the disease that affects the patient, but rather the patient that is affected by the disease. Only then can we hope to find solace for these patients in a timely manner. So you see, non-reductive holism isn't proposing that we only do the biological thing. We do both things together. We consider the psychological elements of medical practice, but we do that in a way that allows us to maintain concern about disease. An alternative approach is found in the National Health System's current pamphlet for management of long COVID, written by a psychiatry group, where you see this graph. You start with the symptoms, you do less to try to cope with the symptoms, and then that causes more symptoms. So the picture here is that based on a concern to avoid the separation of mind and body, psychosomatic medicine construes long COVID as a mind-body overlap disorder best managed in psychiatry. So from that pamphlet, you get these recommendations to patients that if you rest, you'll get more pain, you'll be more tired, then you'll get frustration. What you need is cognitive behavioral therapy, which will help you identify the thoughts and beliefs that maintain your symptoms. So the conclusion to draw here, I think, is clear. There isn't any evidence to support the conclusion that long COVID is caused by psychological distress or psychosocial distress. That conclusion might be true, but at this point, it's supported only conceptually, only through long-standing familiarity with reductive holism and the goal of eliminating the divide between mind and body. There does exist evidence to support the conclusion that long COVID might be a chronic disease that develops from acute infection, and it's just inconsistent with usual standards to reject concern about the possibility of disease in patients who might be in need of disease care. So I found earlier that reductive holism is conceptually problematic. We see here in the end of the day that it is also clinically problematic. I think it's important to point out that this conclusion would have been more convincing if I had done it with rare disease or autoimmune disease, where we know that there is an error in construing the condition to be psychosomatic. I think what's important about long COVID, aside from the fact that it is an enormous and very pressing issue, is that we don't know. And still, in the context of uncertainty, it is very difficult to support the approach that's based on reductive holism. It's really hard to see how that can be a viable way of doing things. Okay. Confusion about dualism impacts public health. And it does seem that if philosophers had been involved in this from the start, or if they were involved in it at this time, medicine would not be having these kinds of problems. So if we accept holism, and at this point, as I said, that's not an idea that I'm arguing for, I'm assuming that at the outset. If we accept holism, the reductive channel is not going to work. If we accept holism, we have to accept a non-reductive foundation for medicine. So at this point, I'm just going to walk through the four central traits of medical non-reductionism and say some things about the philosophical picture that medical non-reductionism is actually aiming for. We will, in the end, need to reject reductionism, reject substance dualism, demand that we revise our understanding of medical science to include experience, and insist that experiences retain their experiential character. For medicine, the combination of rejecting reductionism and rejecting substance dualism is a massive, massive challenge, because at this time, medicine is still struggling with the terminology that allows them to distinguish reductionism from dualism at all. So subtle options between reductionism and substance dualism have just never been on the radar in medicine. And that really is the revelation that's missing in medical discourse about mind and body. As Schneider puts it, contemporary philosophy of mind sees the question of the nature of substance as being settled in favor of the physicalist. Dualism about properties, in contrast, is regarded as being a live option. So this is really the revelation that medicine needs to set holism on the right track. What's needed is really not a lot of very clever and fine-tuned theorizing about mind and body, but really just a very simple translation project. What's needed is really just to clarify the territory between these two poles in a way that is simple and meaningful and actionable for the medical professions. So this is a basic schema of our two options, non-reductive physicalism and naturalistic dualism, is, I think, it's perfectly reasonable to imagine that the medical professions can make sense of these two options and understand their respective merits for the profession. So for both of these perspectives, non-reductive physicalism, naturalistic dualism, all the substances are physical. And for both of these perspectives, mental properties are real. They're not just heuristic devices. So the difference between them then is going to be that the mental properties supervene on or emerge from physical properties on the non-reductive view. So the line between the mental and physical properties is going to disappear at the fundamental level. That means at the fundamental level, the properties don't exist. For naturalistic dualism, alternatively, the line between the mental and physical properties is going to remain at the fundamental level. So the mental properties are going to exist at the fundamental level. This is all very simple and basic, I think, in a way that that can readily be translated into the medical professions. The difference between the two options is, I think, really important for medicine as a science, because for the non-reductive physicalist, science can proceed as usual. The mental properties are going to supervene on or emerge from the physical properties, so they're going to disappear in a fundamental scientific account. But for naturalistic dualism, science has an adjustment to make. And that adjustment very specifically concerns experience. As Chalmers puts it, the fact that consciousness accompanies a given physical process is an additional fact, and it is not explainable by telling the physical facts. So that picture brings us directly back to the general picture of holism that I started with from Borel-Carriot. Engel didn't criticize the mainstream of biomedical research that had fostered so many important advances, but he criticized the excessively narrow focus because it led clinicians to ignore the possibility that the subjective experience of the patient is amenable to scientific study. So this is the third thing that we need to do in order to make sense of medical non-reductionism. We need to demand that we revise our understanding of medical science to include experience, and that demand does give medicine a very clear and simple and direct affinity with naturalistic dualism. In 2018, Hein-Maung considered naturalistic dualism in the context of the philosophical foundations for psychiatry, and in a very straightforward and actionable way, explained how naturalistic dualism isn't just compatible with psychiatry, biological psychiatry as we understand it, but actually there are actually very strong reasons for imagining that this is a picture that biological psychiatry is working with. As Maung would say, criticism of dualism found in the psychiatric literature only applies to traditional dualism of Descartes and not to the contemporary dualism proposed by Chalmers. For the naturalistic dualist, the psychological processes involved in the causation of behavior are explained in terms of physical processes in a biological system, but first-person subjective experience is a further fact that is numerically and metaphysically distinct from the physical facts, but nomologically related to the physical processes. So I think that Maung is exactly right about the way that naturalistic dualism is compatible with psychiatry, and I'm suggesting that this is true of holism in general, that this is the simplest and most productive way of cashing out what holism is actually proposing for medicine's foundations. The thing is that, of course, non-reductive physicalism can also meet the third standard of bringing experience into the exam room. So supervenience and emergence will accomplish that third goal if we understand the way that we stand in medicine currently as a static idea. As a matter of historical fact, though, if medicine had decided in 1977, okay, the biomedical model isn't working, we need to ground medicine in non-reductive physicalism instead, it's hard to see how that would have motivated the 40 years of very powerful effort to move away from the reductive picture of the biomedical model into something different. And this reminds me of the kind of insight that Kim suggested, where it's difficult to see on this view what point there is in recognizing mentality as a feature of the world. It allows mentality to exist, but doesn't strike me as a form of existence worth having. If non-reductive physicalism is the right picture for medicine at this time, it's still going to be very difficult to make sense of the change that it created in medicine as a foundation from non-reductive physicalism. Finally, the most important characteristic of medicine is going to be the one that is the most impactful at the clinical level. So in addition to demanding that we revise the understanding of medical science to include experience, medicine's picture of mind and body is going to have to insist that experiences retain their experiential character at the level of medical science. And in this sense, I think it's clear that naturalistic dualism is going to be the cleanest and simplest and most direct way to cash out what medical holism is aiming for. In addition, it's going to be the safest way, because if we bring mind into the exam room from the foundation of naturalistic dualism, we are going to continue to insist that the line between physical and mental explanations is retained all the way down. So there will be no point where clinicians are tempted to think, well, the line between the two is vague, and so there's no point in trying to draw that line clearly in diagnostic practice. Can non-reductive physicalism meet this fourth standard where we bring experiences into the exam room, but we retain their experiential character at the level of medical science? I don't think so, but that I recognize is an open question, and one with a very complicated answer that I can't begin to address here. I do think that I can say some things about the goal that we would be aiming for with debate of that kind. And these kinds of clarifications can help direct direct considerations about naturalistic dualism versus non-reductive physicalism for medicine. Because here's the thing, in philosophy, we're just looking for the right view. We're looking for the soundest view. We're looking for the details that make the picture work the best. In medicine, we are also trying to find the picture that best helps us relieve the suffering of others and protect others from harm. And that goal changes the kinds of conclusions that we're going to reach about medicine's foundations. So what happens in practice if we accept non-reductive physicalism as medicine's foundations? If all of the questions that clinicians ask are ultimately understood to be physical questions, that is going to encourage the vagueness thesis in clinical practice, the idea that it's a mistake to ever draw a clear diagnostic line between medical and psychiatric conditions, and that's going to result in clinical problems. I should say that if we were designing the right philosophical picture for medicine from a clear slate, this problem probably would not arise. But we are not designing a picture from a clear slate. We have been working with confused ideas about mind and body in medicine for 40 years. And we have reached a point where clinical practice is problematic, and the view that we now develop needs to be one that can address those problems in practice. So it might be possible to find a picture of non-reductive physicalism that accommodates medicine in a way that doesn't force us to accept the vagueness thesis. I think actually it is clearly possible. But I think that it remains unlikely that clinicians could actually grasp that subtlety in a way that's actionable, in a way that keeps clinical practice safe. So I'm just going to suggest, and I think this is the point where I go the farthest out on a limb, clinical practice works most simply and safely on the basis of naturalistic dualism. If non-reductive physicalism is the right philosophical picture, it may be that naturalistic dualism is still the way that we should explain medicine's foundation. Maybe you would construe that as a kind of a noble lie. My sense is that in order for people working in medicine to make sense of the picture of mind and body that's needed, and in order for them to make that work in clinical practice in a safe way, naturalistic dualism is going to be necessary for clinicians themselves. Finally, I think it's important to point out that this debate probably doesn't matter. And going beyond the fact that clinicians are going to have a hard time following the details of the debate, it seems that it's the spirit of naturalistic dualism that matters more for medicine than the letter of it. And we can see that most clearly by going back to the question that I asked at the very beginning. If holism is the antidote to the biomedical model, what exactly is the malady that it cures? We now have a clear answer to that question. The malady of the BMM is its failure to recognize consciousness. holism provides an antidote by insisting that it's possible to do medical science with or about consciousness, I think that we can make that leap in a way that requires naturalistic dualism in spirit, and then go back and reconsider, fine-tune the view, reconsider the commitments that are actually necessary, and maybe we'll find that dualism is not needed. But the leap itself, I think, does require a dualistic spirit. I come to that view based on the historical track of neuroscience. So in 1990, Frick and Koch suggest we need a neurobiological theory of consciousness. We need to look for the neurocorrelates of consciousness. And they base that idea on two assumptions. First, that there is something, experience, conscious experience, that requires a scientific explanation. So that idea is dualistic in spirit, but again, you make the leap, you set out to understand the science of consciousness, and then you can go back and reconsider the philosophical commitments that actually made that leap possible. I think probably there is a more foundational assumption underneath that project, and it's an assumption that drives the similar project in medicine. The idea that we can do science with or about subjective experience without threatening the claim to objectivity. I think that that is the revelation that Engel was reaching for, and I think that revelation is viable for medical science. In the end, I reached these conclusions. In the late 20th century, medical science was on the verge of the paradigm shift that occurred with philosophy and neuroscience, recognizing consciousness as a fit subject matter for science. But medicine's progress along that track was impeded by philosophical confusion that proliferated over decades into systemic incoherence. When we do recognize consciousness as central to medical science, medicine will finally align with the trajectory of philosophy of mind and neuroscience. Okay, that is it for me for this very, very long journey. To facilitate the Q&A, there are these 4 points of review. We will need to revise the areas of medicine that define dualism as separation, recognize that medical ethics does not require rejection of dualism, recognize the vagueness thesis is undefended, and recognize that it's possible for armchair philosophy on the mind-body problem to actually impact the health and well-being of real life people. Okay.
Thank you, Diane, for this interesting lecture. We are already way in the Q&A period, so we're going to have a shorter Q&A trying to be done at 1:30 as we must be. Let me remind you how we're going to proceed. If you have a question, please click on the Q&A button and write your name, and I will promote you to the status of panelist. And I will start now. All right. Jonathan, the floor is yours. John, the floor is yours.
Oops. There we go. Hi. Hi, Diane. Thanks a lot for that. You have a lot more patience and are much more charitable with some of these medical writers than I am, so I commend you on that. My question was about the kind of historical story you're telling, because maybe I'm a bit unclear on it, or maybe I'm a bit unsure about whether it's right. So, so you seem to suggest that Engel brought about some conceptual changes and confusions in medicine. And, surely there are a lot of people who've read and have written about Engel since the 1960s and 70s. You've cited many of them. But, it's my impression that, if anything, I think medicine and particularly psychiatry has kind of gone more towards the biomedical model rather than away from it and embracing different philosophical ideas. So if you think about the time in which Engel was writing, the 60s and 70s, in psychiatry, this coincided with the kind of downfall of psychoanalytic psychiatry. There was a vacuum. Psychiatrists were very unsure about theoretically where psychiatry was going to go. We had people like Thomas Saz saying that mental illness is a myth and that psychiatric disorders aren't physical lesions. And then what happened? Well, what happened was that psychiatry essentially embraced in spirit, if not in theory, biological psychiatry. With the revision of the DSM in 1980, the DSM-3 authors basically committed to the idea that psychiatric disorders were biological disorders that we just didn't understand yet. And so in the meantime, we were going to define and characterize them and classify them using symptoms and behaviors. But the ambition of psychiatry after that point was always to kind of discover the neurological basis of psychiatric disorders. And this biopsychosocial idea is, of course, there in psychiatry today. And I think it exerts some influence on what psychiatrists do. But then in the 2000s and 2010s, we have the National Institute of Mental Health trying to invigorate more and more research into mental disorders and taking as its core science, neuroscience. The neuron is the central unit of mental disorder and psychiatric research after the Research Domain Criteria Project with National Institutes of Mental Health. So if anything, I think psychiatry has moved in the other direction and has embraced biological psychiatry rather than moved away from it. And as for medicine itself, I think there have been some important changes in the sciences that have shaped medical thinking. But I still think that basically Engel's biomedical model, to some extent, describes the way medicine thinks today. So maybe I need to get a bit more clear on what you envision. I mean, I think it's okay to look at that some of these authors that are writing in the critical literature, but the extent to which they actually influence the thinking of medical scientists or kind of like everyday clinicians, I think is a bit unclear.
Yes, I'm with you on that. And I anticipated this question from you. It makes sense to me what you're suggesting. And I should say that, again, nothing I've said argues that holism is the right view and reductionism is the wrong view for medicine, right? So that is a possibility that I just have not addressed in any way. And you're right, the track of evidence-based medicine takes us kind of along a reductionist track where it might seem that the project of holism doesn't matter. But I would point to Gami's book on the biopsychosocial model in psychiatry. There is a deep and fundamental debate in psychiatry between the biopsychosocial model and the biological model. And I think that Mound's paper is really valuable in pointing out that that debate is resolved. If we take naturalistic dualism as the foundation for medicine, it is possible to resolve what seems like a deep and fundamental schism in approaches to psychiatry if we accept holism as the right approach and we cash it out as naturalistic dualism. I think that works. I mean, you might still think that reductionism is the right approach for medicine. I mean, that's a different debate. I mean, I think there's a lot of evidence that that's not the case. But in any case, I think that naturalistic dualism can combine the two in a way that would not lead to any kind of problems on your view.
Thank you very much. Let me see. David, the floor is yours.
I don't hear you. I think you're still on mute.
Hi.
Hi there.
Hi, Edward. Hi, everyone. Well, thank you for the talk. I agree with you that that medicine is taking a reductionist approach, which is maybe not the best way to deal with disease. But here's my question, okay? To simplify, I'm gonna start with the question, then I'm gonna explain it, right? The question itself goes like this: is Descartes really a dualist? and how would that impact our theories based on him? That's why I'm asking this. The idea of a clear line dividing my mind and body used by medicine from Descartes kind of gives to each one of these entities an independent ontological status, right? All of this dualist thing actually came from Descartes' theory of substance, as we all know, right? But then how would this interpretation of dualist tradition, which has methodological and ontological implications, answers to the fact that Descartes' theory of substance isn't actually dualist, but rather is a trialist substance, which is mind, body, and God, which actually is the only independent substance. So based on that idea, there is a book from 1925 called The Mind and Its Place in Nature by Charlie Broad, where he says that Descartes' theory of mind actually considers mind not just as one in number, but as many. So Descartes would be supposedly a pluralist about minds. So how would that impact the debate that you bring it on?
I don't know that it would. I'm not disagreeing with you that there's a way to see Descartes in a broader ontological picture. My sense is that simplicity is really important in this project, because what we're trying to do isn't just to figure out the best philosophical picture of mind and body in the context of medicine. What we're trying to do is to figure out a picture that's clear and simple enough to be actionable in medical practice. Our goal is not just to find the right view, but to find the right view, make it simple, and make it work at the clinical level. So my sense is that while those kind of considerations are important and relevant, it seems that we're better off at this time dealing with things in a very simple way that helps us sort out exactly what the basic components of the mind-body picture are philosophically and how they should translate at the level of clinical practice.
Yeah, but when we change the view of mind, which is based on Descartes, so when we explain that actually Descartes isn't a dualist in reality, and that also changed our ontological perspective. So ultimately that will change our practice, right? So that's the reason. But yeah,
I would need to think about that, but my sense is that once you get to the point where you're looking at what philosophy of mind has done in the polls between reductionism and Cartesian dualism over the last 30 or 40 years, what's needed really is a very simple picture of that territory for medicine. And then maybe once we get that, then we can explore a more subtle and more complicated picture of the kind that you're suggesting, which certainly does seem valuable.
Okay, thank you.
That, yeah.
Thank you very much. If you have a question for Diane, please write your name in the Q&A box, and I'll promote you to the panelist status. All right, Colin, let me do that. Colin, the floor is yours if you can hear me. Somehow I am not sure you can hear me. So meanwhile that you complete the transition, I had a question for you, Diane, and it's a very broad question. So I'm curious to hear what you say. So at the end, you propose a few recommendations for the relationship between mind and body in medicine. And I was struck by the fact that they are all non-contextual, that they seem, at least the way you describe them, they seem to be applying to many different contexts of medicine. But one might have thought that, or maybe that's just the way you use the word medicine, that you had something more narrow in mind. But if you think that medicine moves from, biomedical research on cells at UPMC to the clinical practice of the psychiatrist in a private office, it's a little bit unclear whether we want to have the same, it's not obvious to me anyway, whether we want to have the same attitude for all these type of contexts. So for example, a reductionist pedagogical attitude might be perfectly legitimate in the context of fundamental biomedical science, very far from translation. And a somewhat different attitude might be required in the context of the practice. So I was a little bit surprised, or actually I wanted to hear more about why you don't have a more contextual approach to that question.
That makes a lot of sense to me, actually. The reason why we look for a unified picture is really because that's what holism was doing. You get that tripartite biopsychosocial thing, and you're looking for a new conceptual foundation that makes sense of all three of those in the same go. But what you're suggesting is that it makes philosophical sense to have a different foundational picture of mind and body in different contexts, and maybe different in the biomedical context from the context of psychiatry. That seems completely feasible to me, and something that I should think about.
Great. In a way, my question was inspired by some of Wimsatt's take on reductionism and non-reductionism, not necessarily as metaphysical claims, but as scientific heuristics for doing research. And that gives, or doing research or treating people, that gives a slightly different spin. It actually leaves room for a more contextual approach to these questions. Anyway, Colin, the floor is yours.
Thanks. Yeah, sorry, my computer's really slow making these Zoom switches. And my older computer is faster than my newer computer, so go figure. Anyway, Diane, thanks for that. And I have a question really about what the implications are for thinking about causes if we take naturalistic dualism as our sort of working assumption or working framework, because I think Chalmers is fairly comfortable calling his view epiphenomenalist. Mm-hmm. And I took it that a lot of the point of holism in medicine was really to sort of broaden people's perspectives on the kinds of causes that might be relevant. Now, I could see that you might think, well, once you allow experience in the way that you're experiencing, even if it's only a downstream effect, conscious experience, a downstream effect of some complicated physical system, nevertheless, it turns out to be a really good marker of, or indicator or diagnostic tool for whatever complex of physical causes is responsible that may be beyond our ken at the moment. So that might be the way you'd want to go with that. But I also wondered at that point what work naturalistic dualism is actually doing. So I'm a little familiar with similar discussions that went on in respect of pain. So go back 30 years, and the International Association for the Study of Pain basically formally introduced a definition in which clinicians were urged to take patient reports seriously, because they tended to either dismiss them as being unverifiable or as actively falsified in order to get certain kinds of treatments or drugs or whatever. But I think that people became convinced that, in fact, taking patients' reports seriously led to better treatments without any real position being taken on any form of dualism here, right? So why not just make the same move here?
That's a really good question. And I've started a paper about that I haven't finished. I think that I'm with Chalmers in a kind of epiphenomenal view. I think that medicine is actually dealing with experience in an epiphenomenal way, but only in the way that works for the search for the neurocorrelates of consciousness. It's the very same kind of picture. So what you're doing when you look to see how experiences, psychological distress, whatever, will lead to pain, or how psychological distress can be used as an explanation for pain, when you try to understand that in medicine, you look at brain states, right? You don't look at experiences, you look at the correlates of experiences in the brain. So all of the explanations that we have for the causal influence of experience have to be tracked in medicine through the neurocorrelates of experience, right? So there's no point in the picture where we make the causal leap saying, well, experience did it. Within the framework of medical science, it's always going to be the brain did it, but there's a difference between brain states that are correlated with experiential states and brain states that are not correlated with experiential states. So those two different kinds of brain states are going to lead to different kinds of processes in the medical system. Is that?
Yeah, I mean, I think we're in basic agreement here. I just wonder then why, in what way the more metaphysical aspects of the view are really doing any work here, right? So I know you're on a mission here to sort of clarify the language that is around this discussion in medicine. And I just wonder whether teaching them about, naturalistic dualism and property dualism really does the work that you need it to do, when in fact you could simply point out that ways of assessing the veridicality of patient reports and the effectiveness of basing treatments on patient reports of their subjective experiences are actually medically effective and medically useful and shouldn't be dismissed. And that's all stateable without taking any position or having any metaphysical framing for it.
Well, the trouble with that is the place where we've landed. I mean, that's the general picture that medicine has adopted as holism led to the development of psychosomatic medicine as a profession. What we've ended up with is that picture, but in actual diagnostic practice, that leads to the idea, if you take a reductive approach to that, then that leads in clinical practice to this directive to avoid a clear diagnostic line between the mind and the body in cases where both of those things are possible. And that is a problem in clinical practice that's quite, it's a serious problem in clinical practice. I think the only way that you can address that is to reframe the metaphysical foundation that you're working with, so that reductive holism becomes a non-starter, and you have a picture where you can bring the mind in and yet retain a line all the way down to the bottom of medical science, where you continue to distinguish between explanations in the mind and explanations in the body.
Yeah, so I understand the point about being sort of in a historically contingent moment here. And maybe I'm naive because I don't study what goes on in this branch of medicine, but it sounds to me like you're saying the better strategy here is to replace a bad metaphysics with another metaphysics that might turn out to be bad as well, but it's better than the one that they've got. And I'm like, well, why not just give up on the metaphysics, right? It just like disabuse them of thinking that they should be doing this, but maybe that's naive on my part, right? Just be thoroughly instrumentalist about the value of paying attention to experience. Be holistic in that sense.
Yeah, that's a really deep question for 1:30. But my sense is that it's really important to understand the metaphysical foundations for medicine, because my sense is that medicine is actually about consciousness. the focus of medicine is experience. The goal of medicine is the improvement of experience. And if we don't have a metaphysical picture that explains how that can be possible while we're doing physical science, I think the kind of problems that we've ended up with in clinical practice are going to be unavoidable.
All right, fair enough. Good. We're over time. Thank you.
Yeah, thank you, Colleen, and thank you, Diane. So we've reached the end of our meeting today. Thank you for this wonderful lecture and for this stimulating Q&A. We will see you next week, hopefully on Monday, Tuesday, and on Friday for the next ELS lecture. Bye. Have a good weekend, all, and be safe outside.